Hello, I'm Lin Chang, and I work at UCLA, and I'm very honored to be able to speak at the IFFGD 30th anniversary. And my talk today is Physician Introduction to Irritable Bowel Syndrome. Next slide. So the objectives of this fairly concise talk are to define irritable bowel syndrome, or what we know as IBS, to review the diagnostic approach to patients with irritable bowel syndrome, and to briefly discuss the pathophysiology of IBS and review the treatments for IBS with diarrhea, which we call IBS-D, and IBS with constipation, which is referred to as IBS-C. Next slide. So this shows the key results of a study done by Ollie Paulson and others, where the prevalence of functional bowel disorders, which we now call disorders of the gut-brain interaction, were assessed in the United States, Canada, and the United Kingdom. This was using the Rome 4 criteria, which is a little bit more strict diagnostic criteria. But what you can see from this study is that 1 in every 4 adults in these countries has one of the 6 functional bowel disorders. And the pie diagram shows you these different functional bowel disorders. IBS, that comprises almost 5% of the population, functional constipation, functional diarrhea, functional bloating, opioid-induced constipation, and unspecified bowel disorder, which means that the patient has chronic bowel symptoms, but it doesn't quite meet the symptom criteria for these other defined conditions. Functional bowel disorders are more common in women than in men, but they can occur in both gender. They become less common after midlife. And I'm going to tell you more about them in the next slide. So these are key organic diseases that we think about when we're assessing the differential diagnosis for IBS. And many healthcare providers are always concerned they're missing some other diagnosis that explains their symptoms. And these are some of the main organic diseases that we think about: colorectal cancer, inflammatory bowel disease, microscopic colitis, bile acid diarrhea, celiac disease, food intolerances or sensitivities, congenital sucrase isomaltase deficiency, and small intestinal bacterial overgrowth, which is known as SIBO. Next slide. So since IBS is really a symptom-based diagnosis, this is a diagnostic algorithm that we often go through when we see a patient with IBS symptoms. So we always start off on the left upper box with the symptoms, because that's really what the patients present with. So patients who have recurrent abdominal pain that's associated with defecation and or disordered bowel habits are the main key symptoms of IBS. And when we see them, we do a medical history, includes surgical history, psychosocial, dietary, medication history, do a physical examination, and a digital rectal examination is important in these patients as well for a number of reasons, looking for a rectal mass or for pelvic floor dysfunction, particularly in patients with constipation. We also assess if the patient has alarm features. And the alarm features are important because if the patient has alarm features, which I'll describe in a moment, we might do more specific investigations than we normally do if they don't have alarm features. And I want to show you what those alarm features are. So next slide. So these are alarm features that are more indicative of having an organic GI disorder of the a structural disorder or biochemical disease, inflammatory bowel disease, celiac disease. So the alarm features for IBS symptoms are symptom onset after the age of 50. Now, this is new symptom onset, not an exacerbation of symptoms, but they've had symptoms earlier in life. It's new onset after the age of 50, unintended weight loss, so they're not on a diet, of at least about 10% of their body weight in 3 months, rectal bleeding that is not caused or confirmed by hemorrhoids or anal fissures, or if the patient has melena, which is black stools, nocturnal diarrhea, waking up in the middle of the night to have bowel movements and diarrhea, fever, family history of colorectal cancer or polyps, inflammatory bowel disease or celiac disease, and unexplained iron deficiency. Those are the alarm features that may take us down a different path, diagnostic path, than if they didn't have it. Let's go into the next slide. So this is just showing again the algorithm, but if a patient does not have alarm features, there's limited screening tests that we can do. And this shows you on the bottom table a lot of the culmination of a lot of different guidelines around the world on the diagnostic evaluation of patients with IBS symptoms without alarm features. And you can see that we do order for patients with IBS with diarrhea symptoms, celiac serologies, fecal calprotectin, C-reactive protein. We can consider bile acid diarrhea testing, Giardia stool antigen in the United States because Giardia is prevalent. And in patients with constipation symptoms, we may consider an anorectal physiologic testing for dysenergic defecation. It is not currently recommended to do routine stool testing for infections unless there is a history to suggest they have an infection. Routine colonoscopy under the age of 45, food allergy or sensitivity testing, or lactulose or glucose hydrogen breath testing. Now, we want to do routine colonoscopy just by the guidelines that we have, but that's in all individuals. You don't have to do anything different specifically for patients with IBS symptoms if they don't have alarm features. Next slide. So if the patient has had these limited screening tests, they don't have alarm features, it's negative, and then we look to see if the patient meets the Rome 4 criteria for IBS, which is abdominal pain at least 1 day a week in the last 3 months, and the pain has to be associated with 2 out of the 3 features, or at least 2 out of the 3 features. Related to defecation, so the pain gets better or worse after a bowel movement. The pain is associated with a change in stool frequency, having more bowel movements per day or less bowel movements per week. And the pain is associated with a change in stool form, loose, watery stools, hard, lumpy stools. The patients have to have these symptoms that have started at least for 6 months ago, but they're more active in the past 3 months. Next slide. So let's get back to our diagnostic algorithm. We did limited screen tests. They're negative. They meet the criteria for IBS. And then we tried to subtype the IBS by bowel habit predominance, IBS with constipation, IBS with mixed bowel habits, IBS diarrhea, or IBS unclassified. That means that the patients have pain that's associated with defecation, but when you really look at the stool form, neither of the 2 extremes of stool form are really predominant of at least 25% of bowel movements. Next slide. Okay, so we use the Bristol Stool Form Scale to define IBS bowel habit subtype. We want to do the bowel habit subtyping because a lot of the treatments for IBS normalize stool form and bowel habits. So we have the Bristol Stool Form Scale, widely known as 7 different types. This is the range which we see in the general population, and we define IBS-C and IBS-D and mix by the predominance of the stool type. Next slide. So for IBS with constipation, the patient will have at least 25% of their bowel movements, hard, lumpy stools. And this correlates with slower transit time through the colon. And they have less than 25% of the loose, watery stools, which is type 6 or 7. Next slide. Now, IBS diarrhea, on the other hand, at least 25% of bowel movements are loose, watery, the type 6 or 7, and less than 25% are the hard, lumpy, drier stools, type 1 or 2. And IBS mix, as you can see in the next slide, is really a combination of both extremes. At least 25% of the bowel movements are type 1 or 2, and at least 25% of the bowel movements are type 6 or 7. And this Bristol Stool Form Scale does correlate with transit time. The type 1 or 2, the constipation type, means that the stool moves through the colon slower. And the type 6 or 7 stools, loose, watery stools, the stool moves through the colon faster. Next slide. Now we know that there's a spectrum of bowel habit, these different disorders of gut-brain interaction or functional bowel disorders. If you look at the x-axis, that's the scale of pain. So if you move to the right where the patients have more pain and they have bowel habit abnormalities, they have IBS or could have IBS. On the y-axis, you can see constipation and diarrhea. If you move up the y-axis, that's constipation. So patients with pain and constipation, that's IBS with constipation. But if they don't have much pain on the left upper panel, but they have constipation, that's functional constipation. If they don't, they have more diarrhea, less constipation, but not much pain, that's functional diarrhea. And if they have diarrhea and pain, then it's IBS with diarrhea. So this is really along a spectrum. Next slide. So now we know we refer to functional GI disorders as disorders of gut-brain interaction. And that's because a lot of scientific evidence show that these are a group of disorders classified by GI symptoms related to any combination of the following: motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota, and altered central nervous system processing. Next slide. The IBS pathophysiology is really multifactorial. There's a lot of environmental factors that can increase the risk of IBS, a genetic predisposition or familial predisposition. There can be triggers like food, GI infection, inflammation, and then we can get disturbances in the gut-brain interactions, and we could have some gut peripheral abnormalities that can exist in IBS patients, like altered intestinal barrier function that is termed in the lay public as leaky gut. The bacterial flora can be altered, and the patients have increased visceral sensitivity and can have abnormal GI motility. Next slide. For treatment, there's really a graded response. And you really determine first if the patient has mild symptoms, moderate, or severe. If the patient has mild symptoms, we want to give dietary lifestyle advice, give a positive diagnosis of IBS, and explain about the condition, why patients have it, and reassure them. Patients with moderate symptoms have symptoms that really start impacting their quality of life. And in those patients, we do everything we do in the patients with mild symptoms, but we do continuity of care, manage stress if symptoms are stress sensitive, and we start using pharmacotherapy. For patients with severe symptoms where it's really severely impacting their quality of life, we do also what we do in mild and moderate symptoms, but we start introducing psychological behavioral treatments, continuity of care, central neuromodulators. Next slide. This just shows an overview of the IBS with diarrhea treatments. A lot of it is directed towards the gut, where we want to affect the microbiome. We may use antibiotics, diet, probiotics. If we think the patient has bile acid diarrhea, we may use a bile acid binding agent. For patients with more enhanced gastrocolonic response, meaning that the colon will contract or have more spasm in relation to meals, we may use an antispasmodic like peppermint oil. There are also 5-HT3 or serotonin type 3 antagonists that can reduce symptoms of IBS with diarrhea. And then we have opioid receptor modulators that work peripherally and can help reduce diarrhea and in some cases pain. And then neuromodulators can target the central nervous system as well as the gut and can reduce symptoms of IBS with diarrhea, like pain and diarrhea. Next slide. And then we have IBS constipation treatments, and a lot of them overlap with chronic constipation treatments, which is where patients have chronic constipation, but not really predominant pain. And we have a lot of gut-directed treatment like prokinetic agents that increase the motility of the bowel. We have prosecretory agents that increase secretion of electrolytes and fluid and could improve stool form and also can reduce abdominal pain. And then there's bulking agents for more of the patients with mild symptoms, stimulant laxatives, as well as osmotic laxatives. Next slide. We also have behavioral therapy options and targets. We know that this is a gut-brain disorder that can lead to more maladaptive responses where symptom-related anxiety, which I think is protective and completely understandable, but it can lead to more catastrophizing thoughts, a hyper-aroused system where the patients could lead to difficulty sleeping, more stress-sensitive symptoms, more activation of the cortisol system that we call the HPA system. And it could be more of altered central nervous processing of information, lead to amplification of symptoms. And all of these lead to pathophysiologic mechanisms that we can target with behavioral therapy, like gut-directed hypnotherapy, cognitive behavioral therapy, mindfulness-based stress reduction, and relaxation training. And a lot of these modalities can be used in concert with medications and also diet as well. So you can see that we're moving towards a more integrated approach of diet, lifestyle, medications, behavioral treatment, reassurance, education, and then establishing a therapeutic and successful patient-provider relationship. Next slide. So we really come to the biopsychosocial model that Doug Drossman really brought into the disorders of gut-brain interaction field, where we look at risk factors of early life environment leading to psychosocial factors and physiologic changes in the gut and the brain and the interaction between the two. And they all can interact and affect each other. It leads to the IBS presentation of symptoms, comorbidities, and behaviors, and that can affect outcome. So I think it's important to look at the patient as a whole individual, think about the different factors that can affect their symptoms or the development of IBS and the triggering of IBS symptoms, and then target treatment that is really patient-centered and relevant and important for that patient. So thank you so much for your attention. And I know during the meeting, we'll have a lot of time to talk about the specifics. Thank you again to IFFGD.